Good afternoon, ladies and gentlemen, aficionados on the dais and off the dais. I should thank Dr. Rohit first. It's his magnanimity that I'm here. It's a great pleasure to be speaking in this fantastic meet. It was the year 2009 when Dr. Rohit told me that we'll have to train in keratoprosthesis, and believe me, I had the same expression as this artist has here now. So from 2009 to this year, 2026, we've come a long way in Boston keratoprosthesis, upwards of 250 keratoprosthesis. We have had our set of failures as well. Right, having heard all these talks on the management of microenvironment on the ocular surface, ours is a tad bit different, managing the macro environment, but it still has its place. Right, we've come a long ways from the initial era of the collar button keratoprosthesis. We have varieties, of course. We have the Pintucci keratoprosthesis, the biointegrated one. We also have the MOKP, plus we have the alpha core down to the right. Alpha core, of course, has fallen into disrepute with us. We still persist with Boston keratoprosthesis, type 1 primarily. Right, we do have the type 1, which is the regular one, what we do, the picture on the left. But we can also do the type 2 keratoprosthesis in advanced cases of ocular dryness. Right, for those of you who wonder how the Boston keratoprosthesis looks like, we have the front plate and we have the back plate. Back plate, of course, has got a lot of perforations to allow the aqueous humor to hydrate the carrier graft being the normal human tissue. And we have the locking ring from posteriorly, which keeps the front plate, back plate, and the carrier graft in place. And initially it was only PMMA, but nowadays we do have the titanium back plate, which prevents the retroprosthetic membrane formation, which was known to be a significant cause for failures in Boston keratoprosthesis. Traditional indications have been 2 or more failed grafts which have poor prognosis for repeat regular keratoplasties, and bilateral vision of visual acuity of less than 2200 in the operative eye. And most importantly, it should have good potential for improved visual acuity. Patient selection is paramount. We should always take keratoprostheses which have good tear production. For Boston type 1, which don't have, it's a strict no. Likewise, always assess for good eyelid function, and those which have poor eyelid function is not a contender for Boston keratoprosthesis type 1. They go in for the type 2 variety. And it's best to avoid the severe ocular surface diseases for Boston type 1, as I've said. But we have had our cases wherein we've tried Boston type 1 keratoprosthesis for severe ocular surface diseases as well. For example, this is the one which multiple thrice failed keratoplasties, and we've done the Boston keratoprosthesis type 1 and clubbed it with an EGV, and this is how it looks post surgery. And this is the ocular surface, a 10-year-old kid whom we had with severe grade 4 chemical injury. And this is following the Boston keratoprosthesis type 1, he's now a 24-year-old kid. He's doing extremely well. We can also do it in cases of severe Stevens-Johnson, wherein if it is bilateral, we don't have the stem cells to cultivate and use it. And they also do very well with Boston type 1 keratoprosthesis, maintaining good vision for over 15 years now. We've also done Boston type 1 keratoprosthesis for severe ocular cicatricial pemphigoid. Of course, this is an elderly 84-year-old lady whom we did Boston type 1 keratoprosthesis. Of course, she also had age-related macular degeneration, which kind of reduced the post-op visual outcome. But being one-eyed, she had regained considerably good vision with Boston keratoprosthesis type 1. If you want to see as to how it could be done, this is a case of multiple failed grafts. We do remove the original failed graft. So once this is peeled off, we should be careful if there's any tube inside to preserve the AGV tube, not to cut that. remove the graft in place. So once that is done, we need to assemble the KPro. Right, just trim the remnants of the earlier graft. Now this is the 3 mm punch in the human corneal graft. Now place the KPro front plate upside down, over which the corneal graft comes, and this is the back plate. Now the back plate is pressed over the front plate, the stem of the front plate. So you can notice this is the PMMA back plate. Now once this is done, we need to keep the locking rim so that it clicks into position. Now there. Now we need to just press it so that it snaps into place and the complex is ready. Once it is done, it is sutured in place. Most paramount to note here is that the locking ring has to be adequate, otherwise complications can ensue. It's always easy to do it in multiple failed grafts, but then believe me, there are certain cases when ocular surface is improper, and like in Stevens-Johnson, wherein complication rates may be pretty high. Right, once this is done, it's the regular suturing as we do for keratoplasties. Now, post-op management would include prednisolone topical, QID, tapered over many months, but we always maintain them on topical fluoroquinolone for life. And some of the known complications include the retroprosthetic membrane formation, which is pretty common, and now this is circumvented by the use of instead of using the PMMA, we use the titanium backplate. Can also include corneal stromal necrosis, which is pretty common. Can also have infectious keratitis despite the use of regular fluoroquinolone topical. Endophthalmitis is quite a dreaded complication, but then once we use the locking ring correctly, the chances of endophthalmitis has reduced. Glaucoma is a pain, and the management is a total ball game altogether. These are some of the complications what we've had: severe corneal infections, the keratograft infections, melts, severe melts exposing the backplate. And this is the one whom we've done the refurbishment of the keratoprosthesis. And this is the one which had CF vision, and post-op at 3 months has come up to only 1 month because of posterior segment complications. This is the one who had advanced glaucomatous disc damage and severe infections of the carrier graft. This is how it melts, the carrier graft melts, and we had to refurbish it with another KPro. This is how you can see the inferior melts of the carrier grafts and exposure of the Boston keratoprosthesis, which would require a refurbishment. Now, we've done something called as a refurbishment. We use the same Boston keratoprosthesis instead of using a fresh one. Now, this is how it is done. I'm almost done. So we remove the carrier graft, which is normally around 8.5 mm in size. Now, once this is carefully done, avoid the back plate, injury to the back plate. Just remove the carrier graft. Here you can see it is already melted inferiorly. So once that is done, we carefully remove the back plate we release all the adhesions. Once the underlying adhesions are released, we remove the entire complex in situ. All right, see there it comes out.
Yathish, if we can sum it up, please.
Once this is done, we refurbish it and utilize the same Boston keratoprosthesis. Thank you so much.